Welcome to Clinical Journal Club for this week. The image in the New England Journal is shown here. It's an operative site of a hand. The story is a 51-year-old man with a history of type 2 diabetes, and he's HIV positive. He presents with a 3-year history of worsening swelling of the left wrist associated with pain and numbness in his fingers. On physical examination, he has an extension deficit in the proximal interphalangeal joint of all 4 fingers. Magnetic resonance imaging shows multiple loose bodies in the ulnar bursal fluid. And we're asked, what is this? I don't know. I can't even orient this picture to determine which side the thumb is on, but the ulna is obviously lateral. Not certain. This fat tissue here looks, I think, probably normal. I assume they're talking about this material here. I'm not absolutely certain. But this is not a pigmented villonodular synovitis patient. And this is not Reichel's syndrome. And to my way of thinking, these do not look like calcium hydroxyapatite crystals. And if this is a fibrolipomatous hamartoma of the ulnar nerve, I don't really know. But with the history of the patient being HIV positive and this whole process being indolent and slow, I would probably pick Mycobacterial tenosynovitis due to Mycobacterium avium complex. That indeed is the right answer. So we had to rely a little bit on testmanship in order to get the right answer here. This patient was treated with various medications and looks like it all went away. If we look at the anatomy, there's the thumb side, and this is the ulnar bursa, this fairly large pocket enveloping the tendons shown here. And the ulna is responsible so that we can extend the fingers, spread the fingers from one another. And I think that in the history, the patient was not able to do this. So this infection is taking place here in this operative field. Now, pigmented villonodular synovitis is an old-fashioned term. The pigmentation is visible histologically, and I assume that this is lipofuscin positive or something of this nature. This is certainly not melanin deposit. This diagnosis is actually a giant cell tumor of bone that's fairly indolent, and the term pigmented villonodular synovitis is no longer in use. This is an example of synovial chondromatosis, and this is also a metaplastic condition involving cartilage joint here shown at the elbow joint. Doesn't look like what this patient had today. Calcium hydroxyapatite crystals are responsible for calcific tendonitis, which is a fairly common lesion. Can't really see it here, but this is an X-ray. This is a rentgenographic example of what might be calcium hydroxyapatite crystal deposition. This is can result in chronic pain, various treatments, certainly different than what we inspected from this patient. And here's an example of a fibrolipomatous hamartoma. This one is of the median nerve and not the ulnar nerve, but that also is not exactly what our patient had. Instead, he has Mycobacterium avium intracellulare. And if we, perhaps we'll see this next week, if we look at these big macrophages here, they're filled with the bacteria that they have engulfed. This condition is sometimes abbreviated as MOTT, Mycobacteria other than tuberculosis. When this condition is encountered, one should consider the possibility that the patient might be HIV positive because Mycobacterium avium complex is otherwise quite unusual in the general population. Now, the first topic at the New England Journal this week is Ebola virus. This is a single-strand RNA virus, which is a frightening condition that's seen in subequatorial Africa. This is a fairly infectious disease. It's probably an epizootic that's spread to human beings because of the consumption of what's termed bushmeat. In lay jargon, what they're talking about here is Africans capturing monkeys and eating them. That's termed bushmeat, and the epizootic is probably spread via bushmeat, although it's also easily spread by one infected individual to another. Now, the symptom complex is fairly diffuse, but eventually this results in pneumonia and a hemorrhagic fever, and the entire symptom complex takes place in a matter of days, so that the patients succumb to the condition within about 10 days, and the mortality thus far has been about 50%. We've looked at various papers in the New England Journal and Lancet in terms of developing a vaccine against Ebola virus, and it looks like the results are fairly promising. This particular study is about something else. This is actually a randomized controlled trial of Ebola virus infection, and the patients were randomized to 4 different treatments. And if you look at these treatments, one of the drugs is remdesivir. This is an RNA polymerase inhibitor. Then the other 3 treatments are actually antibodies, isolated from survivors. REGN-EB3 is a cocktail of 3 human IgG monoclonal antibodies that were then engineered and then generated in mice hybridomas. ZMAP is a triple monoclonal antibody cocktail that was developed before these 2 antibodies were. So basically we're talking about 3 different antisera, if you will, if I can use that old-fashioned term, against RNA polymerase. And these patients were diagnosed with Ebola on the basis of polymerase chain reaction, and then were randomized to these 4 treatments. And the primary endpoint was death at 28 days. So here are the patients, and there are quite 673 patients in this trial, randomized to these 4 treatments initially. And these are fairly young individuals. Body weight is given here. They're all slender. Whether or not they've been vaccinated against a putative vaccine against Ebola virus is also given here, and 25% of them were. And various, at the time that the diagnosis was established, creatinine elevations are apparent, and liver enzyme elevations are already apparent, and there are various other clinical parameters are given here. And if we look here, what is seen is, first of all, most of the patients already died in the first 10 days if they're not going to survive this. But the RNA polymerase therapy and the older triple antibody therapy, ZMAP, seemed inferior to these 2 treatments. And when this difference became apparent, the Safety Monitoring Board decided that these 2 less effective treatments would no longer be given, and the patients that were enrolled subsequent to that time received Mab114 or REGN-EB3, these newer antisera against Ebola virus. And what we can see here is that indeed these two antisera treatments were more effective than ZMapp or basically the RNA polymerase drug that was also utilized in this trial. The differences here are highly statistically significant, although they're not massive, but at least these two treatments are more effective than ZMapp. And if we look at duration of symptoms, relatively brief, various other parameters fitting into this logistic regression analysis predicting death at 28 days. What we can see, these are odds ratios, and what we can see here is that, interestingly enough, that patient-reported vaccination seemed to be an indicator of survival. I've emphasized that here, patient-reported vaccination, yes or no, indicating that having been vaccinated seemed to provide a specific advantage for these patients, even if they developed clinical disease that was diagnosed with polymerase chain reaction. Time to first negative result, and we can see here again that these two antisera treatments are superior to ZMapp and to the RNA polymerase treatment. And the viral load, if the patient survives, decreases over time. So that this is a dramatic randomized controlled trial in patients with acute Ebola virus infection, suggesting that these two more modern antisera treatments are better than ZMapp or the drug against RNA polymerase. The next study in the New England Journal involves beta blocker therapy, which is clearly indicated in people with atrial fibrillation or people that have suffered a recent myocardial infarction or people with heart failure. And beta blockers are also effective in patients with arterial hypertension, although they do not seem to protect as much from stroke as other drugs. Now, even though the guidelines committees have pretty much given beta blockers a fairly clear bill of health in patients with COPD, clinicians are reluctant to subscribe beta blockers to their patients, even though some smaller trials suggest that beta blockers could even protect from recidivism in patients with COPD and provide protection against exacerbations. That was the hypothesis in this trial. So these patients with chronic obstructive lung disease were randomized to metoprolol or placebo, and the primary hypothesis was that the beta blockers would perhaps prevent acute exacerbations from COPD, or at least not be harmful, which might be some advantage because many people with COPD have heart failure or atrial fibrillation or other clear indications for beta blocker treatment. And what we see here is that freedom from exacerbation of COPD was not different in the metoprolol group compared to the placebo group. At least beta blockers didn't provide any protection from exacerbation from COPD, which was one of the hypotheses in this trial. But if we look at patients with severe exacerbations, such as they had to go to the intensive care unit, here the placebo group looks better than the metoprolol group, suggesting that perhaps the reluctant clinicians that are not so crazy about prescribing beta blockers to their COPD patients might have a point, irrespective of what the guidelines tell us. So the rate of exacerbation of COPD according to severity was indeed worse in the metoprolol group than it was in the placebo group, as this table indicates. Non-fatal and serious adverse events also really look a little worse in the metoprolol group compared to the placebo group. So maybe the reluctant clinicians had a point. So although beta blockers didn't increase exacerbations in patients with COPD, they certainly didn't protect from exacerbations. And in terms of severe exacerbations, the group receiving metoprolol seems to have done a bit worse. And that bottom line statement is indicated here. Medium time to first exacerbation looks a little worse in the metoprolol group compared to placebo, although that difference is not significant. However, metoprolol use was associated with a higher risk of having a severe exacerbation. Next topic in the New England Journal is chronic myelogenous leukemia. And the peripheral smear in these patients basically looks like a bone marrow examination. Now, we've known since 1960, and this discovery was made in Philadelphia, where I went to medical school, that patients with CML have a peculiar karyotype in these malignant cells. And since 1972, thanks to Janet Rowley, we have recognized the fact that these patients have a balanced translocation involving chromosome 9 and chromosome 22. And this balanced translocation places the Abl tyrosine kinase adjacent to the so-called breakpoint cluster region. And that basically looks like this. The Abelson tyrosine kinase is important to PDGF receptor signaling. All of that is known. And with the balanced translocation, the Abelson tyrosine kinase sits against the breakpoint cluster region. And this rearrangement serves the purpose that the Abelson tyrosine kinase is switched on, which is a state of affairs that we might not want. What we've also recognized is that myristoylation is a lipid modification where basically this fatty acid here is attached to amino groups, and this arrangement serves a signaling state of affairs. So basically what happens in the balanced translocation is that this myristoylated N-terminus, which normally serves to shut the Abelson tyrosine kinase off, is no longer available because it's replaced by the breakpoint cluster region. Now, this new drug, which is called asciminib, can't even pronounce it, but at any rate, it's a replacement for imatinib as a new drug to treat chronic myelogenous leukemia after other drugs to inhibit the Abelson tyrosine kinase have failed. And imatinib blocks the ATP sensitive portion of the Abelson tyrosine kinase, and when that doesn't work anymore, asciminib could fit into this pocket here and block the Abelson tyrosine kinase. That's the idea that was applied in this particular study of patients with CML that were no longer sensitive to imatinib or other inhibitors of this particular tyrosine kinase. So this is not a randomized trial. These patients that had failed these other tyrosine kinase inhibitors all got this drug. And 150 patients were evaluated. We can look at adverse events here, which were of various in nature, but for these patients with otherwise marginal options, I think these are acceptable. Some increases in blood pressure were observed. More common were nausea, headache, and arthralgia. And if we look at the responses here, patients with chronic CML or patients who were already in an accelerated phase of CML seem to benefit from receiving this new Abelson tyrosine kinase inhibitor that fits into this myristoylization pocket. So irrespective of whether or not this particular mutation that I don't know that well is present, the patients seem to benefit from this particular compound. So this particular study shows that patients with CML that are resistant to conventional tyrosine kinase inhibitors have an additional option if they receive this particular drug. So this is one example of a malignant disease that's undergone a dramatic transformation in terms of treatment over the last 15 years, and here's still another innovative possibility. The next topic in the New England Journal is body temperature lowering therapies in patients that have undergone outside of the hospital cardiac arrest. And this is rather a controversial area in intensive care medicine, and we've looked at various studies looking at this issue, but it seems to be that some patients are provided a better outcome by the use of hypothermia. And here's a review that I've found in PubMed on this particular issue. And the strongest evidence for this targeted temperature management, or abbreviated TTM, is in adult patients who undergo an outside of the hospital cardiac arrest and are then brought to the hospital. And the current conventional idea is to lower their total body temperature to a core temperature of about 33 degrees for the first 24 hours after arrival to the intensive care unit. So this study involves targeted temperature management for cardiac arrest in patients with a non-shockable rhythm. If the patients had a shockable rhythm, pulse was restored, and then they didn't need this treatment. So this is a large multi-center study from France where there are 284 patients in the hypothermia group and 297 patients in the normothermia group. And so all these patients made it to the intensive care unit. They were evaluated extensively and received all the benefits of care and ECMO and other resuscitative maneuvers as necessary. And they were randomized to targeted temperature management. I tried to find out how the management was done, and that was rather heterogeneous. And when I worked in an intensive care unit, to conduct this therapy was not trivial. We infused ice saline into some patients. We packed some patients in ice. Some patients received an intravascular cooling catheter. That was fairly common in this trial. Others received closed loop surface devices to lower their body temperatures, and other patients were packed into ice cubes, and in some patients it was, well, actually they pretty much knew what was done to these patients in both groups, but this was a heterogeneous approach to applying hypothermia, and this treatment technically is not trivial and is certainly onerous for the personnel that work in intensive care units. But what we can see here is indeed the hypothermia group had their core body temperature lowered to about 33.5 degrees for the first 24 hours in the intensive care unit, and then by the time 40 hours had arrived, if the patients were still alive by then, there was no difference in core temperature in these two groups. The other patients that received conventional care that didn't receive this TTM therapy had a body temperature of about 37 degrees throughout in this particular study. Did this help these patients? Well, apparently it did, because there are neurological outcomes that can be measured by various tools, and these neurological outcomes looked a little better in the patients with the temperature management compared to the normothermia group. Now, the first thing that we can appreciate is that vast majority of patients in both groups died. But this outcome is better than the outcomes that we observed 10 or 15 years ago. So management of out-of-the-hospital cardiac arrest has improved, probably because of ECMO and other modalities that are now available in intensive care units. But what we see here is that this pattern of survivors was favorably shifted in the patient in the hypothermia group compared to the normothermia group. Now, how these patients eventually function and whether or not they can take care of themselves remains to be seen, but there is a significant advantage here for the hypothermia group compared to the normothermia group. And indeed, these external cooling packs that are now available for these patients that involve both thighs, the abdomen, and the thorax to cool these patients is better than applying ice cubes or infusing iced saline, modalities that we applied 10 or 15 years ago when I worked in an intensive care unit. So this will probably be the standard of care for the few years to come in patients with outside of the hospital cardiac arrest that don't respond to defibrillation. Now, we looked at this young patient last week, and this is an example of hydrocolpos. In this infant, hymenal incision solved the problem, so this patient didn't have one of these less common genetic causes of this problem, and patient did well. The next patient, if we can look at these röntgenograms of these hands from this poor patient, we see the marked destruction of the metacarpal phalangeal joints and dislocations here, and the marked destruction of proximal interphalangeal joints is shown here. And this poor patient has telescopic fingers, and this is a sequel to chronic rheumatoid arthritis. Hopefully today this poor patient would be managed differently so that this end result would not occur. The review in the New England Journal is on penicillin allergy, and this is an important review because many patients, including myself, for example, have been told that we are allergic to penicillin, whereas penicillin and other beta-lactam antibiotics are the drugs of choice for a variety of severe infectious diseases, and that's the discussion here. And what the discussant tells us, first of all, the mechanisms of how penicillin allergy comes about. And you can inspect this review and learn all about that. But the discussant mentions how the diagnosis of penicillin allergy is commonly far greater than the actual existence of penicillin allergy, and many individuals that are labeled as penicillin allergy really are not allergic to penicillin, and that clinicians have to consider this possibility of beta-lactam antibiotic is definitely the drug of choice, and there are skin tests and direct challenges that can be conducted even in children. These are discussed in this review, and a strategy for penicillin allergy delabeling and drug safety according to risk is outlined in this particular schematic that's shown here. So the number of patients that are actually allergic to penicillin is probably quite a bit smaller than what's perceived by the public or what the patients are told by their physicians. And there's also an oral penicillin desensitization protocol that the discussant here demonstrates in this table. So appropriate history taking and risk stratification could result in a better treatment for patients that should be receiving penicillin that otherwise would not be able to receive the drug. The patient in the New England Journal is a 20-year-old man with a history of electronic cigarette use, known in English as vaping. So this patient comes in with a history of vaping, and he has airway complaints, and a situation that takes place over a period of weeks as he goes from one emergency room or from one physician to another. Oxygen saturation is pretty reasonable. Initial CT examinations, although the radiologist sees some things that I don't really look too bad. And 9 weeks later, he's still in the pulmonary clinic with complaining of cough and sputum production, and the patient had also observed some dyspnea on exertion. Vital signs are okay, and oxygen saturation is okay. Differential diagnosis is fairly broad. The patient has a DCLO value that indicates some problems with gas transfer. Bronchodilator testing doesn't seem to be too helpful. Of course, the patient was already initially warned about vaping and that he should stop vaping, but apparently he did so only later in the course of his disease. Various studies looking at anti-nuclear cytoplasmic antibodies and various other possibilities, MPO antibodies, these studies were basically negative. And so finally the patient presents at Mass General and still has dyspnea when climbing stairs, and drinks 12 beers on the weekends and smokes marijuana, but otherwise claims that he doesn't use illicit drugs, and here's some more vital signs that are all right. And eventually some laboratory information is accrued here, which isn't initially terribly helpful. Some elevation in C-reactive protein, alkaline phosphatase is a little bit above normal limits, erythrocyte sedimentation rate, great test. It's a bit elevated, but now his CT is different, and he has these various infiltrative lesions that are now that even I can appreciate on CT, that have gotten much worse. And the patient now claims that he stopped vaping some weeks earlier, but now these lesions are present. Various other antibody tests are performed. A urinalysis was normal, and then a diagnostic test was performed. And we can imagine that it probably was an invasive test to find out what's going on in his lungs. And so the discussant discusses pulmonary edema, and he discusses various infectious possibilities, and then he discusses various inflammatory conditions that might have been responsible for this diffuse bilateral widespread lung disease in this patient that participates in chronic vaping. Could this be blood or hemorrhage? And I guess it could possibly be so. Diffusion capacity for carbon monoxide is mentioned here again. And actually the discussant considers vasculitis with alveolar hemorrhage, even though ANCA and MPO antibodies were not detected in this patient, and is concerned about vaping, but this patient doesn't really look like the vapors that we've seen in previous papers in the New England Journal. So this biopsy indeed shows lots of hemorrhage, and hematoxylin and eosin staining is shown here. Abundant neutrophil infiltrate. Capillary inflammation seems to be the point here, so maybe the idea of some antibody or pauci-immune mediated alveolar hemorrhage is reasonable, but the final conclusion is that this example of diffuse pulmonary alveolar hemorrhage is related most likely to the vaping habit. Now in the Lancet, the first, and this is complicated for me because I'm certainly not an expert in this area, the first two papers involve partial breast irradiation. We know that patients with breast cancer, even without substantial metastatic disease are subjected to irradiation therapy because there's very good evidence that irradiation therapy decreases the chances of local recurrence. And the question in these studies that we're going to look at is that could this irradiation therapy be confined to that area of the breast that's involved with the malignant disease, or should the whole entire breast be irradiated, which is currently the standard treatment? Then we look at this accelerated partial breast irradiation. Some of these patients received brachytherapy, and brachytherapy is a procedure that involves very localized placing of radioactive material inside the body where the lesions are present, as opposed to external beam irradiation, which is another possibility that can be applied in patients receiving accelerated partial breast irradiation. So in the first paper, what we look at here are these are patients with breast cancer. These patients have localized breast cancer. The tumors are relatively small. They were accepted in this study if they had several positive lymph nodes nonetheless. And they received either total breast external irradiation or accelerated partial breast irradiation, either through the brachytherapy, which I assume was done by a catheter-like device, as I just showed you in the illustration, or external local accelerated partial breast irradiation through external beam irradiation therapy. Now, in these papers, exactly how this is done isn't really shown. So the illustrations that I got out of the internet for you are my preconceived notion of how this therapy was provided. 2,000 patients in both of these groups, and most of the patients are younger, ethnicity, etc. Randomization seems to have worked, and what we see here is that the local accelerated partial breast irradiation and the whole breast irradiation, the difference here is less than 0.7%, not statistically significant. And so it looks like both forms of treatment are acceptable. The argument in this study was to try to show that the local irradiation was no worse than the whole breast irradiation. And that event was not totally convincing. The absolute differences in ipsilateral breast tumor recurrences were small, so the authors suggest that the accelerated partial breast irradiation would be an acceptable treatment, but the study wasn't entirely convincing. The next study is a similar study looking at external beam accelerated partial breast irradiation versus whole breast irradiation. A similar collection of patients were recruited, and in this particular study, also large numbers of patients here. This is reality. This is if we spread the ordinate a little wider, but there's no difference in the two treatments in terms of efficacy and local recurrence. And this study would imply that the accelerated partial breast irradiation is no worse than whole breast irradiation for these women. Now, the next topic in the Lancet concerns cholesterol. I thought we already knew this. There are lots of risk calculators. The favorite is probably the Framingham risk calculator that considers your age and serum cholesterol, HDL cholesterol, and your blood pressure. Now, if you're a Lancet reader, you're forced to deal with these values in millimoles per liter instead of milligrams per deciliter. Perhaps for cholesterol, milligrams per deciliter is perhaps a little more exact because these molecules are very large, which makes millimoles per liter a bit cumbersome, but there are conversion calculators that you can also access in the internet that allow you to change millimoles per liter to milligrams per deciliter. Now, what was done in this study, although I thought we already knew this, this is an evaluation of 44 cohorts in a huge consortium database to again look at total cholesterol, non-HDL cholesterol, and the risk and the eventual cardiovascular risk, and perhaps the construction of still another risk calculator. So we're looking at 500,000 individuals here in this huge evaluation of this massive database here. Some of them received cholesterol-lowering medication, probably for good reasons. Here there are LDL values, HDL values, and their non-HDL cholesterol values as shown here. And as we would expect, the higher your non-HDL cholesterol, the greater your problems, and that's the case for women and also the case for men. And if you have low cholesterol values, you're probably a little better off. So greater than 5.7 millimoles per liter would be a non-HDL cholesterol value of 220, and less than 2.6 millimoles per liter would be about 100 milligrams per deciliter. And so if we look at these results, pretty much what the textbooks already tell us, and what we also can appreciate from looking at this database is a similar study looking at sorry about that. The higher your cholesterol values, the greater your risk, but if you're far over the age of 60, it's probably irrelevant. And this calculator is also a value only for individuals that are under age 70, as shown here. So there's again evidence for positive outcomes for lipid-lowering individuals, and having high cholesterol values is a bad deal, at least if you're under 70 years of age. The review in the Lancet concerns air pollution and chronic airway disease, and the discussant here raises the point that perhaps it's not really much ado about nothing, but it may be much ado about something that's not quite as important as everybody says. And what do we really mean by air pollution? And when is air really polluted, and when is it not? And does the burning of biomass really cause chronic obstructive lung disease? Probably plays a lesser role than smoking, I would think. And according to this author, in terms of biomass and risk, doesn't look nearly as great as what we've otherwise been told. Wood only and other biomasses risks for men and women are greater than the 1.0 line that's shown here. Yes, it is, but not as great as we've been told in the past. So the author doesn't really claim that air pollution is trivial, but he does suggest that some caution should be exerted in terms of claiming that air pollution causes chronic obstructive pulmonary disease. Now, the patient in the Lancet is this patient, has knee pain, and if we look at this plain röntgenogram, he's got some patellar destruction, and don't know exactly what this is. The physicians thought that he might have a giant cell tumor on the basis of this MRI examination, but when they operated on him, all they found was inflammation. That's probably enough. Now, they dropped this specimen into formalin, which dissolves uric acid crystals. But even though they can't show the presence of uric acid crystals by means of strong negative birefringence because they dumped this specimen into formalin, they nevertheless got their little report into the Lancet, which makes me a bit envious because another preparation would have probably shown these sodium monourate crystals and their strong negative birefringence. That's it for this week. In 7 days, we have the 25th of December, which is a holiday in Europe. And 7 days after that, we have the 1st of January, another holiday in Europe. I'll put the files into the internet as usual every week anyway, but we'll meet again on the 8th of January, and I'll give an amalgamation of the best papers that are published in the meantime. Have a nice holiday, and thank you very much.